In today's video, we are diving into 3 trigger points that can fix 90% of low back pain, and you absolutely don't want to miss the last one. Stick around until the end and I'll show you exactly how to treat these trigger points like a pro. Let's get started. We begin with one of the most underestimated powerful muscle in back pain, the iliopsoas. Anatomically, the iliopsoas consists of 2 fascicles, the psoas major, which originates from the 12th thoracic vertebra and descends diagonally, and the iliacus, which arises from the inner surface of the iliac fossa. These 2 muscles fuse together and insert into the lesser trochanter of the femur, forming the iliopsoas. Now, to understand where we're palpating, we can use some external anatomical references. The extension of the iliac crest line gives us a rough indication of the L3-L4 spinal level, and from there we can assume the origin of the psoas is just slightly above and deep to that. Since the psoas descends at an angle fusing with the iliacus, we need to palpate in that direction. But before we do that, it's essential to activate the muscle to identify it correctly. So we ask the patient to contact the rectus abdominis. We do this by asking them to flex their head while lying supine. While they do that, we palpate the external surface of the rectus abdominis. Then we ask them to relax the head back down, and we position our hands like this, placing gentle pressure and asking them to flex the hip. At this point, I can feel the psoas contracting under my fingers, confirming its location. This is a key step because the iliopsoas is the main hip flexor, and unless we activate it, it can be hard to distinguish from surrounding structures. Let's also keep in mind that the nerve innervation comes from L1 to L4, and this will help us to understand the pain often associated with this muscle. But here's the warning. When palpating the iliopsoas, we must be extremely cautious. There are 2 main situations we can encounter. We may be palpating close to the abdominal aorta or iliac arteries. If we feel any pulsation, we must immediately change position depending on the patient's body type, but this region can be deeper or more superficial, so stay alert. We may encounter the visceral package, including the intestines. In this case, deep palpation can be uncomfortable or refer pain elsewhere. So we adjust gently, making sure the patient is relaxed and not experiencing any disturbing sensations. Now, exactly where we're palpating, we can also identify and treat trigger points of the iliopsoas. The best technique here is the ischemic compression method. Here is how it works. We apply gradual, sustained pressure directly onto the trigger point, using either the flat pads of our fingers or, if the patient's body requires more precision, just the index and middle fingers. The pressure should be firm but not sharp, just enough to engage the muscle fibers without causing unnecessary pain or activating nearby visceral structures. We maintain that pressure steadily for 60 to 90 seconds. During this time, it's essential to communicate with the patient. So ask them, do you feel any radiation? Is the pain local or referring somewhere else? Trigger points in the iliopsoas usually radiate to the lower back, hip, groin, and even the front of the thigh. If the pain diminishes or the tissue begins to soften under our fingers, that's our sign that the trigger point is releasing. We can repeat this 2 or 3 times in the same spot if needed. And once we feel the muscle density return to a more normal tone, we move to the next point. Next up is the quadratus lumborum, or QL. Here's a pro tip. When dealing with the QL, a small position change makes a big difference. We can stretch the QL more effectively by asking the patient to cross their legs, which lowers the iliac crest and increases the space between the crest and the 12th rib. In this position, the QL is already slightly stretched, making the ischemic compression even more effective. We lean gently over the patient and apply pressure to the identified trigger point using our thumbs or fingers. Remember, this is a very sensitive area, so always observe the patient's reaction closely and adjust your pressure accordingly. We prefer this crossed leg position, especially when the iliac crest is so close to the rib that the palpation becomes difficult. By stretching the QL, we create the space we need to access the trigger point effectively. Now let's address another common source of referred pain, the gluteus medius. Here's what we do. We ask the patient to perform hip abduction, lifting their leg while we apply resistance. This contraction helps us palpate the gluteus medius and minimus, both of which are hip abductors. With the muscle activated, we use flat finger palpation to scan for tight bands or trigger points. When we find a particularly tense area, we ask, is this where you usually feel pain? Does it radiate down the leg? If the sensation radiates down the leg, it likely means we've hit a gluteus minimus trigger point. So we should move slightly closer to the spine, where the gluteus medius trigger point is usually located. That one typically refers to pain on the same side lower lumbar spine. We then apply ischemic compression for 60 to 90 seconds using steady, deep but controlled pressure. Once the muscle releases, we move on to scan for other trigger points in the same muscle group. And there you have it, 3 powerful trigger point zones that can dramatically reduce back pain in your patients. If you found this video useful, don't forget to like, subscribe and leave a comment if you have any questions or case studies to share. Check the links in the description to explore our courses and click the side thumbnails for more videos about manual therapy. Thanks for watching and I'll see you in the next video.